This video represents CPR during the COVID-19 pandemic. The correct use of PPE is vital during resuscitation. You can assess the patient in level 2 PPE, which is a surgical mask, apron and gloves, eyewear if indicated. First of all, make sure the area is safe to approach. Once it is, gently stimulate the patient and see if there are signs of life. If there's not, call for help by whatever means is available to you. Then open the airway with a head tilt chin lift manoeuvre or jaw thrust. One of the changes of COVID-19 is assessment of the patient. To assess for normal breathing, we just look at the chest. We do not listen and we do not feel for breathing. You can, if you're trained to do so, check a pulse whilst assessing breathing. Once you've decided there is no normal breathing, i.e. the patient is in cardiac arrest, you must leave the scene and don full PPE to begin chest compressions. Chest compressions are an aerosol generated procedure. Once you have donned full PPE, return to the patient and begin CPR at a ratio of 30 compressions to 2 ventilations. However, chest compressions on their own can be performed without any form of ventilation. So if you have no equipment or are unable to use the equipment, it is perfectly okay just to do chest compressions. If a colleague arrives again in full PPE, you can ventilate the patient with a bag valve mask device attached to oxygen if available, but the bag valve mask must have a viral filter attached between the bag and the mask. To use the bag valve mask in an adult, it's a 2-person technique. One person will squeeze the bag and perform compressions. The other person will open the airway and maintain the airway whilst hanging onto the mask. Continue CPR at a ratio of 30 to 2 until help comes, you become exhausted, or the patient shows signs of life. For paediatric resuscitation, the etiology of cardiac arrest is different. Children tend to have a secondary cardiac arrest as a result of hypoxia and or hypotension. They generally do not have a primary cardiac arrest. Resuscitation of children should still have the same level of PPE as that of adults. Initial assessment of the child should be performed by gentle stimulation, but do not shake the child. Call for help if the child is unresponsive. Open the airway and check for normal breathing for up to 10 seconds. Once the child has no normal breathing, then we want you to ventilate the child 5 times with a bag valve mask, again with a viral filter attached in full level 3 PPE. For paediatrics, we begin with 5 initial breaths. Once those 5 breaths have been delivered, if there is no response, then begin CPR at a ratio of 15 compressions to 2 ventilations. The 2-finger technique can be used if you are the solo rescuer. When additional help arrives, the other person can perform CPR using the thumbs technique, or if they wish, the 2-finger technique. In paediatric patients, it's perfectly acceptable to use 2 hands to do chest compressions, or conversely 1 hand to do chest compressions, depending upon the size of the child and the strength of the resuscitator. Paediatric choking may occur at any age. Once you have taken control of the child, we want you to place the child in a head down position so that gravity assists you, and begin with 5 back blows. If nothing is removed from the airway, turn them over onto their back and deliver 5 chest thrusts, and continue 5 back blows and 5 chest thrusts until help comes, the object comes out, the patient improves, or the patient becomes unconscious as a result of choking. If they become unconscious as a result of choking, then we will need to begin CPR as per resuscitation protocol. In the event of a maternal cardiac arrest at Conquest or Eastbourne DGH, dial 2222 and ask for the maternal cardiac arrest team. For all other locations, dial 999 and ask for an ambulance. The ratio of compressions to ventilations is the same as that of an adult, 30 compressions to 2 ventilations. The depth of CPR is the same, 5 but no more than 6 centimetres. The rate is the same, 100 to 120 beats per minute. The major issue with pregnant women is that of aortocaval compression syndrome. In essence, as the slide illustrates, the weight of the baby compresses the major blood vessels, in particular the inferior vena cava and the aorta. To relieve aortocaval compression syndrome, we must alleviate this by either providing manual displacement of the uterus, if we wedge the patient, we need to tilt them to the patient's left-hand side. If the patient is wedged and you're going to perform CPR, then you need to be on the patient's left-hand side. So they are wedged to the left and you do CPR from the left. The other major important point for pregnant women of certain gestation, we need to perform an urgent perimortem section, and this should be undertaken at 5 minutes after cardiac arrest has started. The perimortem C-section is designed to help resuscitate the mother. We may resuscitate the child, but the primary goal is to optimise resuscitation by performing a PMS to deliver the child.